what we might do today is, there's a lot of questions out on the road from whether it be students, practitioners who are inexperienced, just coming out in their first year, or even long-standing practitioners who may be working for companies or practicing in their own clinics. A lot of questions about PCOS. And do you find yourself, when you meet up with clients with PCOS, do you find that they also require a lot of help for adrenals or thyroid as well?
Absolutely. Yeah, so with PCOS isn't a simple condition. It's not as simple as kind of, yep, there's PCOS, there's a PCOS supplement. There's a lot of different subtypes of PCOS, and for someone to get to that degree of metabolic and reproductive imbalance, there's a number of things that need to occur. So you've got stress involvement, which involves the adrenals, you've got blood sugar involvement, there's definitely mood involvement, there can be a number of things. And I find there's three main subtypes of PCOS that we see. One of them heavily involves the adrenal glands, and most have some element of adrenal, if not all. The second one is really strongly on more insulin resistance and that kind of subtype. And the third is thyroid. And thyroid related. So, and obviously there's a mesh of all of that, but I find often people have, definite areas in one of those three.
And a question that's often common out the road is, where would you prioritise your treatment strategy?
So it depends on the patient, because it's all about taking their history and finding out what's going to be right for them. Because if you have someone with PCOS and they come in and you only treat their hormones, it's not going to work. I would always prioritise adrenals and gut over hormones, because if you don't have that foundation, it means that you're just kind of pushing crap uphill, really. So I guess it's looking at their individual case, and I might not necessarily start everything at once. I might go, okay, well, you really need to look at detox and gut health, because until we do that, we're not going to be able to detoxify hormones or move anything there. Sure. Or we need to manage their stress and get them sleeping, because until we do that, their hormones aren't going to have any chance of regulating. So it's really just looking at the whole patient and seeing what's going to work for them.
So you train the individual in any case?
Of course, yeah. We're naturopaths. That's what we need to do.
That's what we do.
Yeah.
It's interesting out in the road, though. You hear so many practitioners who are looking for those, almost like having a 1, 2, 3 process, but it is about treating the individual.
Mm-hmm. There's no protocol, and there's definitely protocols that we use in certain situations. And when we have our interns or new practitioners come through, certainly we're workshopping that and go, okay, when someone presents like this, we find this combination works well, but it's not a bullet, not a silver bullet.
Sometimes it's easy if we had that, but that's not. Like
silver bullets would be good. They would also put us out of business.
Yeah, exactly.
But they'd be great.
That would be nice. And then when we're looking at dietary for PCOS, what are your thoughts on fibre, cruciferous vegetables, phytoestrogen-rich foods? There's a lot of information and confusion out there about the good, the bad, the ugly.
Yeah, so all three of those we need, definitely. But you're treating often a metabolic condition with PCOS, so you need to look at diet. We need to look at diet anyway, but it's particularly important, because no matter how much supplements and herbs you throw at them, if you don't have that foundation, they're not going to get better. And often their diet is what's gotten them there in the first place. So fibre is important, definitely, and definitely important from a blood sugar regulatory perspective as well. But also we need to making sure that we're allowing the body to detoxify excess hormones, and fibre will allow them to do that. It's going to pull it out of the bowel. Cruciferous vegetables are something that we use, and obviously we'll be using things like diindolylmethane and other derivatives like that in a supplement form. But by them eating cruciferous vegetables, it can help them to detoxify and balance out estrogens and support their liver and antioxidants. You do have to be careful that they're not having too much raw cruciferous vegetables, because they can be high in goitrogens if they have thyroid issues going on, particularly if they're low in iodine. But definitely, their broccoli, cabbage, cauliflower, radishes, kale, all that type of things are definitely foods that I'd be recommending.
And do you ever get any side effects that you see in your clients from too much of the cruciferous vegetables, like too much salt or amino acids?
Like if they're getting like bloating and things?
Exactly.
Not unless they're having heaps of raw stuff, and it depends how I'm getting them to prepare it. So I might get them to make like a cauliflower soup or something like that. But if they're getting those symptoms, then we're looking back to gut and what's going on with them too. But I haven't had too many people have major problems at the levels I'm getting them to eat.
Yeah, so it's all about the balance and the warming foods.
Yeah.
And is there any elimination diet that you would look at when you're looking at this sort of client?
Yeah, so with a PCOS client, I'm eliminating sugar, definitely. I mean, with all my clients, I'm eliminating sugar, but I'm a lot more strict on it. I'm eliminating simple carbohydrates. Often, depending on the patient and where they come from with their diet, I might be eliminating like all grains for a temporary period. So maybe almost like what I love for PCOS, if they're able to do it, is more like a paleo style diet, maybe with some quinoa and buckwheat in there, maybe a little bit of oats, something like that. So I definitely like it to be gluten-free, wheat-free, and I definitely like to get rid of dairy for them. If they just can't get rid of dairy, then I eliminate low-fat dairy. Like that's just a big no-no with PCOS.
And do you ever get some really resistant clients who maybe they're level A executives and they're so used to taking, the little sugary hits?
Yeah.
Is there anything you do to really, I guess, reduce that craving?
Yeah, we definitely look at using chromium and I mean, because we're working on balancing their blood sugar with PCOS, we're going to be using like our chromium and zinc and, all of our other beautiful blood sugar balancing nutrients and herbs as well. Selenium being another one of them. So you just need to help them with the craving side of things. If they're really stuck though, they're like, I just can't give up my chocolate at 3 p.m, then we send them to our hypnotherapist.
Oh, you got a hypnotherapist here as well?
Yeah, to sort them out.
Wow, that sounds fabulous.
Yeah.
So the ideal diet is really about balance and warming and cooling foods. When it comes to nutritional supplementation, there's a lot of information out there on herbal intervention, but there's a lot less information with PCOS on nutrition. What are the key nutrients that you prescribe? And if possible, the sort of dosages, I guess.
Yeah, okay. So off the top of my head.
No. Sorry to do that to you.
That's okay. So chromium, definitely. So chromium, well, what's the dose? Probably about like 150 micrograms 3 times a day. So with every meal I'd be doing that. Selenium, depending on where they're at, I'd be using between 100 to even 300 micrograms a day, like depending if they've got thyroid stuff or that type of thing going on. Zinc, about 50 milligrams a day. Give or take a little bit. So they're probably the key nutrients that I use, and then there might be a few others, but it's, normally I'm using them in a compound with other things going on in there, but they're probably the key nutrients that I'm using from a blood sugar perspective. And then from a more ovarian health perspective, I'm using things like inositol often, and depending on the type that I'm using, like if I'm using just a straight inositol, so not the kind of D-chiro and myo inositol, etc., I'd probably be using about 1,000 milligrams a day. But it depends on the patient.
Yeah, gotcha.
Yeah, and also N-acetylcysteine, actually, always with PCOS. Yeah, more recently, which isn't really that more recently these days, is it?
I think the research is definitely more recent as far as having a look at the dosages for PCOS, fertility and hormones regulation. I was going to ask you about microbiome and microflora with PCOS in particular.
So, I mean, a lot of our hormones are metabolized in the gut, and if you've got dysbiosis, which most people will to some degree, but if you've got a dysbiosis occurring, there's not enough of your good bacteria, there's too much bad funky stuff going on, then it's going to affect your metabolism there. So always we're looking at gut health. We're looking at, are they passing bowel movements regularly enough? Do they have the fibre there to kind of bind and carry things through? But also it's worthwhile having a look at to make sure that their microbiome's healthy. So we do a lot of stool testing for that, particularly if they are presenting with digestive problems and they have that going on. I would love to do a CSA for every single patient if money was no option, but sometimes it's not possible. But it's definitely a consideration, because that's your foundational stuff. If you don't get the gut stuff right, then the rest of the stuff just won't work as effectively, in my experience.
And that was my next question about testing. So apart from stool analysis, are you checking just regular pathology with glucose? Are you doing fasting glucose testing for some of them?
Yeah, so we do fasting glucose in the clinic and random glucose just because we can in the moment. But usually blood pathology is the first way we go. We've got some doctors that we work with, so often it doesn't cost them a lot of money and we can get quite a broad range of testing. And when you're looking at PCOS particularly, you want to have your luteinizing hormone, follicle stimulating hormone, sex hormone binding globulin. You can't get those through saliva. So having the blood panel is a good first place to start. I will go to salivary hormone to have a look at the estrogen breakdown. But if their hormones are crazy all over the place and I want to look at adrenals, I'll actually do the Dutch hormonal urine testing, which is relatively new, and that then shows you all of your breakdown of your different types of estrogen, your cortisol, cortisone, DHEA. It actually will give you the full picture of how things are being broken down. So that can be really helpful as well.
And whereabouts do you find these pathology testing, some companies?
So Research Nutrition does the Dutch hormonal panel, they're who I do my stool testing through. I just find their bacteriology and fungal analysis is just way superior to anything here so far. And then salivary hormone, I use Nutripath, but I know that there's HealthScope and a number of other people that do that. And if I'm looking at blood sugar testing, I'll usually be doing a HbA1c and insulin through the blood test, and the doctor's usually pretty happy to do that.
Do you find that PCOS clients tend towards symptoms other than typically seen in anovulation?
Yeah, so if someone's just anovulatory, so most commonly being it'll be like post-pill amenorrhea, I guess, is what you'll see. That's probably, if someone's not ovulating, it's most likely going to be PCOS or post-oral contraceptive pill amenorrhea, or, they've got primary amenorrhea from ages ago. But usually with PCOS, you're going to be, depending on their presentation, if they've got high androgens, you're going to be more prone to increases in facial hair, more prone to acne, more prone to weight gain, that type of thing. They're probably like the biggest differences that you'll see there, but also with PCOS, I find, as opposed to someone who has just amenorrhea and they're not ovulating, you get more fluctuations. So although they might not be ovulating, they'll get these hormonal fluctuations that'll cause PMS-like symptoms. So it'll kind of flare up their moods, or they might get bloated or snappy, or they might get insomnia. So you'll get, as the body's trying to do its thing in the background, you'll tend to get these little fluctuations that'll occur. So I guess that's probably the main difference that you'll see.
So in regards to nervous system neurotransmitters, do you tend to go towards herbs or nutrients, or a combination of both for that?
Combination. Usually with everything I'm treating, I'm using a combination of herbs and nutrients. It's pretty rare. Actually, I would never do one or the other with a patient. It's all because they work so well together.
Yeah. Is there anything, do you have a love for a certain amino acid in, let's just say, anxiety or depression?
Yeah, well, obviously like tryptophan is going to be up there, and glutamine, and GABA, and working on that pathway. But N-acetylcysteine, like, you can't beat it these days. It just covers everything so beautifully, and it's such a low cost treatment as well. So that's always usually thrown in there.
And maybe reducing some of that compulsion. Compulsion to have a sweet, or compulsion to act out.
Yeah, that's right. It just covers off so many things so beautifully. Yeah.
Okay, so a couple more questions from the road. Would you treat these symptoms as they come to you, or would you look at causative factors first? I guess that's a tough question.
You've got to do a bit of both. You've got to treat the symptoms, because if you don't treat the symptoms, you'll lose a patient. But with PCOS, a lot of the symptoms won't go away until you treat the cause, until the hormones are corrected. So I always educate my patients that we say that there's 3 levels of care that we're going to take them through. The first part is symptomatic, where we're giving them things that are working on the symptoms, but if they stop that treatment in 2 to 4 weeks, they're just going to come back again. And the next part is corrective care, where we're working on actually correcting the cause and underlying issues, and that normally takes us kind of anywhere from 6 to 12 months with PCOS. And the third level of treatment is called wellness care, and that's where we know that we've treated the cause and they just need that little bit of wellness to actually keep them there. So we're always going to treat the cause, but it's a little bit like you have that cause and effect. And a good example, I guess, is looking at gut health. And if we treat the cause, which might be the imbalance in microbiome, that's going to take us 6 months to really kind of get a dent in that. But if we give them herbs that are going to help to increase their stomach acid and enzymes and just reduce bloating and calm everything down, it's going to get them feeling a lot better and digesting better, so that we can actually get to that root cause a bit better.
And do you see, talking about digestion, do you see many cases of low hydrochloric acid or enzyme production in especially PCOS clients?
Yep, in all clients. But yeah, I wouldn't say in particular in PCOS clients, but in all clients, because someone's stressed, their little acid pumps, they're just going to stop producing acid. So you see it all the time. Very, very common.
Very common. Now, this is an interesting question. Have you treated people diagnosed with PCOS in the absence of any glycemic, insulin, or metabolic issues?
Yep.
You have?
Yeah, so you see people, well, because it's a complex of, so I've seen a few patients where, actually I've seen a lot of patients where they have blood sugar imbalance symptoms, but it's not showing up in their blood tests. So they don't have insulin resistance as such, but they have symptoms. So for instance, they might be thirsty, urinating frequently, waking up during the night to go to the bathroom. They might feel a bit like there's floaters in their visual field. They might get hangry, or they're getting kind of these glycemic kind of episodes. So we see a lot of that, but it doesn't show up in the blood test. So I don't think that means that it doesn't have an effect on their condition, but it's just they haven't gone far enough that it's actually causing an insulin resistance yet. On the other hand, I have seen a few patients where they just don't have any of those symptoms. So they've got high luteinizing hormone, high androgens, hormones, they've got the hirsutism, they've got the acne, they can't lose weight, they're not ovulating, they've got an irregular cycle, but they don't have any signs of insulin resistance in their blood work, and they don't have any of those symptoms at all. So it's quite interesting. I'll normally treat them with a low dose of that type of treatment anyway, which it just seems like they kind of need that in some sense, but they're not symptomatic. So it's a bit of an anomaly, but it does happen.
I think that's just about every question. Thank you so much for answering a lot of questions in regards to your clients and general population on PCOS. Thank you for joining us at the Education Centre, and thanks for your time.